welcome to Chicago. My name is Eric Armbrecht. I'll serve as your chair for the Midwest CEPAC today. We have 17 members of the Midwest CEPAC here today for our discussion on treatment-resistant depression. And we're all thrilled to be here. We've had a lively morning with great discussion on the topic of MS. And we'll continue, I think, our thoughtful dialogue with all of our partners that have come to join us. We thank our clinical partners and our patient partners for joining us today to discuss this topic. It's customary sort of order of business that we introduce ourselves as members of the Midwest CEPAC and also let the audience know if there have been any changes to or updates to your conflict of interest statement. My name is Eric Armbrecht. I'm a professor at St. Louis University's Center for Health Outcomes Research, and I have no conflicts of interest.
Good afternoon. I'm Scott Misek from the St. Louis College of Pharmacy and a pharmacist at Barnes-Jewish Hospital. I have no conflicts of interest.
I'm Tim McBride at the Brown School at Washington University, and I have no changes to my conflict of interests.
My name is Nicholas Bagley. I'm a professor of law at the University of Michigan, and I have no conflicts of interest.
I'm Don Casey. I'm an internist. I have faculty appointments at University of Minnesota Institute for Healthcare Informatics, Rush here in Chicago, and Jefferson College of Population. I have no conflicts of interest or relationships with industry relative to this topic.
Hi, Albert Huang. I'm a general internist, professor of medicine at the University of Chicago. No conflicts.
Greg Kerfman, deputy editor, JAMA. No conflicts.
Jill Johnson, professor at the College of Pharmacy in Little Rock, Arkansas. I have no changes to my conflicts.
Bijan Bora, professor of Health Services Research at Mayo Clinic College of Medicine, and I have no conflict to declare.
Stacy Doucette-Zena, Stacy Doucette-Zena. I'm an associate professor at Vanderbilt in the Department of Health Policy, and I have no conflicts.
I'm Harold Pollack. I teach at the University of Chicago School of Social Service Administration. No conflicts.
Ryan Barker. I'm the Vice President of Health Policy for the Missouri Foundation for Health, and I have no conflicts.
I'm Kurt Van Bosch. I'm a pharmacist at the St. Luke's Health System in Idaho, and I have no conflicts to disclose.
Timothy Wilt. I'm a general internist, health services researcher at the Minneapolis VA and University of Minnesota. I have no conflicts.
I'm Aaron Carroll. I'm a professor of pediatrics at Indiana University School of Medicine, and I have no conflicts.
Stuart Winston. I'm a cardiologist and patient experience consultant in a large multi-specialty group in Ann Arbor, Michigan. And I have no conflicts.
Good afternoon. I'm Ray Mustafa. I'm an associate professor of internal medicine, Division of Nephrology and Hypertension, director of outcome and implementation research at the University of Kansas Medical Center, and I have no conflicts.
Steve, we'll turn it over to you.
Thank you, everybody. Again, thank you to those who are returning after a hard morning's work. We're putting you through your traces today. Thank you to the new attendees and to those of you watching via the webcast. You've just been introduced to the Midwest CEPAC. I'm Steve Pearson, the president of ICER. And I just want to tell you briefly again about ICER, as we serve as the convening host of these public meetings and as the academic secretariat for the report that serves as the foundation for the discussions and the later policy discussion. So ICER is a not-for-profit research institute based in Boston. Our funding is kept updated on our website as a pie chart where you can see that 77% of our overall revenue comes from a series of nonprofit foundations. Our largest funder is the Laura and John Arnold Foundation. We have at least 4 or 5 others in that segment. We do take direct contributions from health plans and provider groups of about 8% of our revenue and from manufacturers for 13%. That is allocated specifically to a policy summit program where we convene them, their leadership, to talk about evidence-based medicine and future policy, and it is not used to support the research that goes into these reports and to support these meetings. So why are we here today to talk about this particular topic? I'd like to start with a couple of quotes from patients or patient representatives in the area of mental health. While there are numerous medications approved to treat depression in several therapeutic classes, SSRIs, SNRIs, and MAO inhibitors, the common experience for people living with treatment-resistant depression is a repetitive cycle of trial and error with multiple combinations of these existing medications. And from a patient, I used to be suicidal 250 to 300 days out of each year. Treatment with ketamine lifted me out of this black hole. Now I'm suicidal about once a year. It's kind of a shame that when that's viewed as a positive outcome for any individual person, but you can tell the difference that it's made for that individual. And so we're here today because we have an unmet need, and we'll hear more about that. The fact that these patients really do cycle through a tremendous series of treatment options and possibilities, with some responding, some not, some relapsing after they do have initial response. And so there's a significant unmet need, and ketamine and esketamine may represent really important advances to address that need. Anytime we have brand new treatments, we also have to look at the background in which we have increasing healthcare costs that affect not just the systems of care, but individuals as well. So these new mechanisms of action come in with the excitement and the interest in where to apply them, and they raise a lot of questions about what's their appropriate use, which patients could benefit most, how does the clinical world react to incorporate this new treatment in the best way possible. And we still know that despite all the efforts, well-meaning individuals and organizations, we have a healthcare system in which patients often have difficulty accessing the treatments that they need. And that can include anything from a high out-of-pocket financial burden to insurance rules that require lots of twists and turns or hoops to get to a treatment, and just lots of issues that are a tangled web linked to the price, the cost, and access questions that we'll try to untangle today. So we do think that as part of that, and an important starting point, is to have an independent review of the evidence on the clinical effectiveness and to try to capture the value. There are different ways to think about value, and we're going to tell you about how we try to bring that forward in our reports and into the context of a public meeting to try to advance the discussions that we need to have. So first, though, we have kind of an overall approach to how we do our reports that begins with a scoping phase. And what we mean by that is that when we identify a topic, and it's frequently linked to a new drug or other treatment coming into the system, we reach out to the existing patient groups and to the manufacturers, and we say, teach us. Help us understand the arc of innovation and the development of this treatment, where it comes from, where were the blind alleys, what did we learn along the way, what do we still need to learn. From patients, we really need to know, what does this lived experience with this condition mean for you, and for what value means to you and your families? What different, we may think we know a clinical kind of stereotype of what it is. Teach us about the diversity within that. Teach us about how it feels different in different points in time and from different types of patients and families. And really also help us understand, with whatever evidence that there is for us to look at, where are we missing what matters most to patients? Help us know among the different clinical outcome measures, which do seem to capture it best, but help us understand really well where it's not capturing yet what does matter to patients. Then we go off and do a staff review of the existing evidence. And hopefully sometimes we can reach out and find new evidence from patient-reported outcomes or different sources that haven't been part of formal decision-making before. We engage with outside academic colleagues, as we have on this occasion, on both the clinical effectiveness analysis and the cost-effectiveness analysis. And for the cost-effectiveness analysis today, you'll hear from researchers at the University of Illinois at Chicago, who perform the cost-effectiveness modeling. All of this work goes through multiple iterations of bouncing ideas and issues off of the patient community, clinical experts, and the manufacturers, and has a phase of very formal public comment and revision. And we were very fortunate to benefit from expert review on this report from two physicians who are here with us today, Dr. Christina Cousin, sorry if I'm pronouncing that. Could be Cousin if it was French, we'll figure that part out. And Dr. William Gilmer, I'm on more solid ground with that one probably. You can see their associations up there, and we'll hear from them shortly as well. And from Felix Foxworth, thank you very much, who is with us from the Depression and Bipolar Support Alliance. So as I mentioned, we have this conceptual idea of value that we think it's helpful to bring into the public debate, not to be held just behind closed doors. And what does our view of that picture of value look like? Well, first, we start with a goal that we know that in their hearts, certainly, all partners in the healthcare system share. And that is the basic idea that we should be seeking fair price, fair access, and future innovation. And we know that sometimes those are hard to bring into perfect alignment, but that we need all three to have the kinds of care for patients that can be sustained over time and that will really make the best use of the resources that we do spend on health. So we think that decision makers should think about achieving that goal by looking at two different conceptual pieces. One, long-term value for money, and I'll talk more about it in a second, as well as short-term affordability, because the two are not the same thing. And when they're in conflict, the healthcare system sometimes gets into trouble. So first, long-term value for money is itself comprised, in our view, of several important different categories of data or information. One is a clear-eyed look at the best evidence we have on the comparative clinical effectiveness of different treatment options. Two is a look at the long-term incremental cost effectiveness as modeled in a simulation based on the clinical information that we have. There are also two other important pieces to this. One is what we call other benefits or disadvantages. And those are aspects of value that often are particularly important to patients and families, or health systems or others, but which are not captured by the clinical data or by the cost effectiveness modeling. So we want to be sensitive to the possibility, at least, that there are these other benefits or disadvantages that we want decision makers, from patients to clinicians to payers and manufacturers, to keep in mind. And surrounding, in some ways, all of that is the fact that there are always contextual issues around, is this a very, very serious condition for which there are no other treatment options? Is this a lifelong problem or a short acute phase kind of treatment? What do we know more about the levels of uncertainty for both risks and benefits? So we try to wrap all of that certainly into our written reports, and you'll hear about it in the discussion today. For short-term affordability, we will spend less time in the public meetings, but it is an important part of our report to talk about the potential budget impact of new treatments. Because in some ways, we always want good long-term value for money. If we're not, even if we get that, it can be sometimes that there are so many patients that are out there who need treatment and we want to treat them quickly that will bump up with a short-term affordability problem, even though we have the long-term value. So we need to keep that in clear view and make sure that policymakers are confronting that potential tension as early as possible so that patients don't get caught in the middle of an access and affordability problem. So the agenda for the afternoon, a 4-hour phase in which we'll start with about an hour of presentation and discussion around the evidence, both on comparative clinical effectiveness and incremental cost effectiveness. We will then have a short phase of public comment and discussion, following which we will move directly into further deliberation on the specific voting questions that we have for the CEPAC on value and effectiveness. We are going to have a small break, followed by the policy roundtable discussion, where we will try to take the evidence and the discussion that's preceded during the early part of the afternoon, and then move towards talking about how it could be applied in the best ways possible to future research priorities, to coverage criteria by insurers, to clinical understanding of how to structure practice to make sure that the right patients are treated and in the best way possible. So we'll try to figure out how we project the evidence into those kinds of policy areas. And we'll finish up with a round of reflections from our Midwest CEPAC panel members themselves, and be sure to be done by 5, so that you can all hit the lovely 5 p.m. traffic outside these doors. All right, with that, I'd like to thank also our clinical and patient experts who joined us at the front table here today. Would you mind actually just introducing yourselves? And we have up there, I believe, whether you have any potential, interests that could conflict in some way with what you have to say. But if there's any change to that, or if you wish to comment on it further, please do. But Dr. Gilmer, why don't we start and we'll go down the row? Oh, you know how these work? You have to actually push it continuously.
Bill Gilmer, I'm a psychiatrist, a clinical professor at Northwestern University here in Chicago. Recently took on a role of psychiatric director of research at the Hines VA, and there are no changes in my conflicts listed.
Thank you.
Hi, I'm Christina Cousin. I'm a psychiatrist at Massachusetts General Hospital at the depression program. I've been doing research on ketamine for almost 10 years, and I have a large ketamine clinic. I'm an assistant professor at Harvard Medical School, and there is no change in my conflict of interest.
Okay, thank you.
I'm Phyllis Foxworth with the Depression and Bipolar Support Alliance. I live with a mental health condition, as do several members of my family, and I have no conflict.
Thank you for being here.
My name is Pamela Goloski, and I'm a patient with treatment-resistant depression who's been taking ketamine for over a year now. I have no conflicts of interest.
All right. Thank you again for being here as a resource to all of us in the discussions we'll have today. So with that, let me introduce Dr. Steve Atlas, who's an associate professor of medicine at Harvard Medical School and the leader of our review on the comparative clinical effectiveness information. Steve.
Good afternoon. So I'm going to give a brief introduction to the clinical evidence and present that, and then we'll turn over. To the Dan Touchette for the modeling. Feel free to interrupt me along the way if you wish, or I'll try to leave 10 minutes to go through things at the end. The work that I'm going to present is not really all my work. A lot of it is done by Felucia Agbola, Catherine Fazioli, and Naomi Flush, who all work with me and are at ICER. So the background, we're going to be talking about major depressive disorder, and the symptoms of that include persistent sadness, hopelessness, loss of interest or appetite, decreased energy, trouble sleeping or concentrating, and suicidal thoughts. We're going to focus today on treatment-resistant depression, which refers to a depressive episode with an inadequate response to therapy of adequate dosing and duration. We'll talk a lot about what that definition actually means and how it may vary among studies shortly. Major depression is a common problem. About 16 million Americans suffer from it and have at least one episode in a year. We define treatment-resistant depression. About a third of patients don't respond to our initial therapies. And those with treatment-resistant depression have higher costs of care, decreased work productivity, and account for a lot of money, $64 billion in total cost to the system. Depression has a huge impact on patients' lives. It can affect quality of life, ability to work, and overall economic well-being. For many, the current medications that we have available do not provide long-term relief or have intolerable side effects. Those who have refractory disease, multiple episodes of failing different medicines, may turn to therapies such as electroconvulsive therapy or repetitive transcranial magnetic stimulation. These, while can be effective for some individuals, have high rates of relapse when they stop. They're time-consuming, they're inconvenient, and especially for ECT, can be associated with long-term cognitive side effects. As a result, some patients have turned to off-label type treatments such as ketamine, and we'll talk about that shortly. In terms of common treatments, antidepressant medications, the classes, the selective serotonin reuptake inhibitors, SSRIs, or the slightly newer serotonin norepinephrine reuptake inhibitors, along with atypical antidepressants such as bupropion, are common medications for treating these patients. For those who do not respond or have side effects from these first-line therapies, there's a variety of different options. You can modify in a variety of different ways, these antidepressant regimens, or you can augment them with other therapies, and we'll talk about those such as antipsychotic medications. There can also be things like depression-focused psychotherapy that may be added, but most experts will not view these as standalone therapies for those with treatment-resistant depression. And as mentioned, other strategies may be tried, such as ECT and TMS. The potential new target that we're going to talk about today is the N-methyl D-aspartate, or NMDA receptor. And this interest in this receptor has been based upon ketamine, which is an anesthetic that has been around for decades and that has been associated with improved symptoms and has moved in an off-label fashion to be used for individuals with treatment-resistant depression. So the scope of our review this afternoon is going to be to evaluate the clinical effectiveness of a new medication, esketamine. It's available in a nasal spray, plus a background antidepressant for treatment-resistant depression. We're going to compare it to a variety of different things. One will be the background antidepressant alone, what we'll refer to as placebo. We'll also compare it to other active treatments, ketamine, ECT, TMS, other antidepressants that we looked for, as well as the augmentation with drugs such as the antipsychotics. The outcomes that we'll be focused on is symptom improvement, clinical response and remission, relapse, quality of life, and I'll define these shortly, and then a variety of different harms, such as nausea, vomiting, dissociation, sort of the high that you can have from medications like ketamine and esketamine. And then suicidal ideation, as Steve mentioned in his quote, and increased side effects such as blood pressure. The main body of the evidence for esketamine comes from 4 phase 3 multi-center trials. 3 of these were similarly designed 4-week randomized trials, and we'll refer to them as Transform 1 and 2 are the most common ones, and these were in patients, adults 18 to 64. A similar trial, Transform 3, was conducted in older individuals, 65 and greater. Sustain 1 is the other randomized trial, and this was actually evaluating withdrawal to see if you stop esketamine, what is the rate of relapse? What is the duration of benefit of this drug? And then as a non-randomized trial, Sustain 2, this is an open-label, 48-week trial that primarily evaluated long-term safety. We also looked at comparator RCTs that met our eligibility criteria and found 1 phase 2 trial of ketamine that we'll discuss. There were also trials for TMS, including 11 sham-controlled trials and 1 trial that compared ECT and TMS. There were 2 trials of antipsychotics that both involved olanzapine that we found and evaluated. We'll focus more on the ketamine trial, and we'll have less to say about these other trials, as I'll mention. For the ketamine trials, this just presents an overview of the information in the trial and several key points. These are the Transform 1, 2, 3, and the Sustain 1. All of the treatments with the active agent in 3 of the trials involve flexible dosing of either 56 or 84 milligrams of esketamine. The Transform 1 was notable that it was a fixed dose trial. As you can see, in terms of the age, the Transform 3 trial represented an older age population. The duration of symptoms in this episode was on the order of years, and it varied among the different trials. And importantly is the definition of what defines treatment-resistant, that only about a third to 40% of patients had failed 3 or more drugs. The standard definition is 2 or more drugs is defining a failure, and we'll talk about that a little bit more in a moment. And then finally, there is the baseline severity. The MADRS score is a validated outcome measure of symptom severity, and these measures were in sort of the moderate to severe range of depression for patients in these studies. In terms of the key outcomes that we looked at, so the primary outcome, as mentioned, is the change in MADRS scale from baseline to follow-up. This is a 10-item question that has a 6-point rating scale, so it's a 0 to 60 scale. As mentioned, the patients had scores in the upper 30s. A minimal clinical important difference is between 1.5 and 2 in terms of change that have been shown in that score. Secondary outcomes that we were interested in was looking at sort of clinical response, so a greater than 50% improvement in the MADRS from baseline defined clinical response. Remission was a score of less than 12, which indicated less mild symptoms or less in terms of the depression. Relapse was defined as the MADRS going back up to being greater than 22 on 2 consecutive assessments in these trials, or hospitalization for depression, suicide attempt, or other events. And then finally, while I won't present data from them, there were other patient-reported outcomes that were studied, that, including the Patient Health Questionnaire, the PHQ-9, which is a common measure, and the Sheehan Disability Scale. We spoke with patients and had discussions, and the highlights from those included the recognition for the need for new therapies for those who have not responded or intolerant to therapies. Patients emphasized the dramatic impact on all aspects of life, relationship with friends and family, disability, and economic hardship resulting from their depression. And that some described in great detail about how they found benefit from off-label drugs like ketamine, and also expressing interest in a on-label drug such as S-ketamine. So let's talk about the results. So one of the key findings was that there were key differences in the S-ketamine and comparator trials that really prevented us from being able to perform a network meta-analysis. We found differences at many different levels, such as entry criteria, the definition for treatment-resistant depression, the number of medicines varied, what was qualified as the amount of improvement on those medicines varied, so that was one factor. The other was that there were differences in the populations in terms of the severity of symptoms, the duration of symptoms for patients entering different trials. The study designs varied, the choice of how additional therapies were given in addition to the drug of choice, sort of concomitant antidepressants, what was allowed. Some studies included new antidepressants, some including antidepressants that they had already failed. And then there were also differences in terms of the endpoints, the outcomes that were measured, and how they were assessed. So we were not able to perform a meta-analysis for this. However, given the similarities between the Transform 1 and 2 trials that I previously described, we did perform a meta-analysis of these 2 trials, and we'll present results from that. So in terms of the primary outcome, this is the change in symptoms, symptom improvement. These are the Transform 1 and Transform 2 study results at 4 weeks. And again, the Transform 1 was a fixed dose of 56 or 84 milligrams, and the placebo and the esketamine Transform 2 was a flexible dose. And what this shows is that there was a improvement in patients given esketamine, the mean difference, the difference in difference of between 3 and 4 in these different trials. When we did a meta-analysis of the Transform 1 and 2, we found greater improvement on the MADRS score for esketamine compared to placebo, with a mean difference of 3.8. The Transform 3 trial had a similar improvement, but these were not statistically significant differences, as shown. In terms of clinical response and remission, these are also data from Transform 1 and 2. And one thing that you can see in both these trials is that there was a high response rate in the placebo arm. And just to remember, the placebo arm included patients getting a placebo nasal spray, as well as all patients got an additional antidepressant at the same time in both groups. So the response in the trials, 37% or 47% of patients had a placebo response, though higher in those who received active esketamine. And similar findings were also seen for remission. Yeah.
The antidepressant in the placebo, it was a new one that patient had just been on?
So that's a great question. So in fact, it was a new in terms of that episode, but the patients may have actually been on it in the past. It was an open-label choice among the study psychiatrists of one of 4 different drugs. They did not provide information about how many of the patients had been on these medicines at any time. Very few patients had been on them in that current episode, but many of these patients, as you can imagine, had had multiple episodes previously. Great question. So in the meta-analysis, we found that patients on esketamine for the clinical response were more likely to achieve a clinical response that's less than 50%, a greater than 50% decrease in the MADRS compared to placebo. There was a similar relative risk for remission, but this did not achieve statistical significance, as shown. So turning to the ketamine trial, so this was a phase 2 trial of IV ketamine that looked at outcomes over a 2-week period. The population was similar in terms of age. They had a mean MADRS score of 35 that was similar. The percent who had failed 3 or more regimens was less than the esketamine, which was sort of 30 to 40%, 15% here. And what you can see is that in the ketamine arm, there was a similar magnitude of response and remission. One thing to highlight is there was quite a bit lower response in the placebo. And as Dr. Kusin has spoken to me about placebo responses, that this is much lower than what you typically see in trials. And this may be due to functional unblinding in this population. But the point is that the magnitude of the response among people who got ketamine was actually of a similar magnitude to those in the esketamine trial. Turning to relapse, this was the SUSTAIN-1 trial, and among 700 patients enrolled, there were 176 patients who achieved a stable remission. And if you didn't achieve a stable remission, that's the less than 12 on the MADRS score, there were another 121 who achieved a stable response, that less than 50%. And among the stable remitters, patients who were randomized to stay on esketamine were less likely to relapse than patients who were randomized to go back to be changed to placebo. And similarly for stable responders, esketamine reduced relapse by 70%. Turning to the harms of esketamine, most patients who received it had more adverse events than those who received placebo. Most were mild to moderate and resolved on the day of dosing. These included nausea, dizziness, dissociation, sedation, and clinically important increases in blood pressure were noticed. Patients receiving esketamine were also more likely to discontinue treatment over the 4-week trial. There was no evidence of drug-seeking behavior or misuse or abuse in the esketamine trials, but the FDA label includes a boxed warning that requires this risk evaluation and mitigation, or REMS, program. In the 48-week open-label trial, serious adverse events, including suicidal ideation attempts, occurred in about 6% of patients over a 48-week period. It's also worth noting that during the 4 phase 3 trials, a total of 6 patients died, all of them in esketamine treatment. Only one of them, though, was included in one of the controlled trials. The others were all in the open label. And 3 of these deaths were by suicide, though none of them were ruled as being directly related to the drug, because it was periods of time after they had actually received the treatment. we can talk about that more later. Turning to controversies and uncertainties, our experts view esketamine as an option for those with chronic severe depression who have failed multiple other options. There was a lot of questions about uncertainty for any new drug, about who may benefit most from such a new therapy. And there was some concern about, given the side effects of esketamine, that blinding may have been difficult to maintain, and it wasn't clear reported in the trials. There's also uncertainty about the benefits and risks of long-term use of esketamine. And that while there were no reports of misuse or abuse, there's the REMS program because of concerns related to diversion and abuse issues with ketamine itself. In terms of other benefits or conceptual considerations, esketamine does offer a novel mechanism of action that's similar to ketamine and may be a real option for those who are not finding relief or have not tolerated other therapies. And that we recognize that treatment-resistant depression is associated with a large unmet burden of disease. That said, it's unclear who may derive the greatest benefit from this drug, such as the issues around the severity of the baseline symptoms, how long the patient has had depression symptoms for, the years with depression, as well as other psychiatric conditions that may exist in patients with depression. There's a lot of uncertainty about who may best benefit from this. And though patients expressed interest in new therapies, they were also cautious about esketamine given the nature of its dosing. An intranasal spray isn't so easy for some patients. And also it still requires coming to the doctor to be administered in the doctor's office because of the REMS program that the FDA is requiring. In terms of public comments, eskedamine's manufacturer wanted us to emphasize the results of the TRANSFORM-2 trial because of its flexible dosing as being the most relevant for clinicians and patients. We decided still to perform a meta-analysis of the TRANSFORM-1 and 2, and our reasons were that both were phase 3 trials by the manufacturer in patients who met the same eligibility criteria. They both used the same dosing options, the 56 or 84 milligrams, and both of them included the addition of a background antidepressant. And they assessed outcomes with the same measures in the same time points. So those were our reasons for performing the meta-analysis. So in summary, comparing esketamine versus placebo plus background antidepressant, we found that the drug improved symptoms and response in adults 18 to 64. It also improved remission and showed similar effects in adults 65 and older, but these were not statistically significant findings. For those who were responding or in remission, we found that continuing esketamine resulted in decreased rates of relapse. The side effects included dissociation and increased blood pressure, along with the risk of suicidal ideation. And importantly, there's very limited data on long-term use, and given the evidence from the issues around relapse, long-term use of this medicine is something that is likely to occur. And then finally, we were not able to do a head-to-head comparison of evidence of esketamine versus other drugs, ketamine, as well as in the same manner, TMS, ECT, or olanzapine. So this led us to our evidence rating of esketamine plus background antidepressant versus background antidepressant alone as being promising but inconclusive. And then there was insufficient evidence in our rating to compare it to these other active agents. So I'll end there and be glad to answer any questions that folks have.
Thank you for a very good, thank you to you and your team for preparing such a great presentation for us. Tim, would you like to kick us off with the question?
Thanks. And again, nice job along with the morning session too. So I'm just confused as to how, this may stun the people around the table here, how you got an I or a P/I. Compared to the data we saw this morning, we have 4 randomized trials in relatively comparable patients, one is older, with benefits that are 2 to 3 times the MID and the MADRS score, improvements in relapse and remission, and side effects that are, quote, mild and self-limited. And we get an I/P versus a B+ on one trial. I know we're not supposed to compare across mornings and afternoons, but there just seems to be really inconsistency, and that troubles me. I would have given this way better than a P/I. I know that's what stuns people around the table.
Yes,
I'm thinking I
suffice.
probably should answer this since I'm involved in both those reviews. Is this on? Yeah, okay, good. So the P/I means that we're not certain that there's no harm on net, and that we consider the possibility of benefit up as high as the B+. There's no difference on the upside compared to the B+, but we're saying that we don't feel that harms have been adequately excluded, and that's for 2 reasons, I think primarily, and we can see whether Steve agrees with this, but one is that these drugs are going to be used long-term, and we don't have tremendous long-term data. And the second is that we were troubled by the increase in suicidal ideation and suicide in obviously patients who are at high risk for this. And so while the PI says we're hopeful that this is a really good drug, we're a little worried that harm could crop up. And that's what the PI means versus the B+, which says we don't think on net that there's going to be a downside. In fact, we don't think on net there's worse than a small benefit.
Stacy?
That well reflects our discussions that were quite long and drawn out.
So just a quick question about the way that these drugs, esketamine, is administered. Could you talk a little bit about the dosing and sort of, it sounded like there's a bit of time the patient needs to spend in the office, and maybe contrast that with ketamine and how much time people spend there?
Right, so I can't contrast it with ketamine. I may ask one of our experts to do that. But the device for esketamine is a 28 milligram dispenser that provides 1 spray, and you use it. You have to wait 5 minutes, and then the dosing is either 2 canisters or 3. That's the 56 or 84 that are then given over a 10 to 15-minute period. In terms of ketamine can be given IV, as well as it's also being used intranasally as well, though there's really we did not find any published data on the intranasal version, though the data that I did present was the IV. Dr. Kusin, do you want to comment on how ketamine is used, given?
There is an intranasal study.
Can you use, thank you.
There is a published intranasal study on ketamine, but after that study, the FDA would not allow to conduct any study on intranasal ketamine above 40 milligrams. So that has been very challenging to obtain any fund for research on ketamine intranasal because the FDA would not allow it for fear of for lesions observed in rats and potential toxicity of ketamine intranasal. Well, you can conduct any study you want on ketamine IV, and the doses we have studied up to 1 milligram. I'm surprised you didn't cite that. We did a study of 4 different IV doses of ketamine, large multicenter, and sponsored by NIMH, 4 different doses of IV ketamine versus active placebo to avoid unblinding versus midazolam IV. And all the doses were better than the active placebo. But you cannot conduct studies on ketamine intranasal above 40 milligrams, which is a dose clinically not very helpful. So this is the challenge of research and why there are no control studies. In terms of clinical use for intravenous ketamine, we administer an infusion of a low dose of ketamine over 40 minutes, and the patient remains with us for observation between half an hour to an hour maximum, especially in elderly patients. And they are released to an escort. They cannot drive, they cannot operate machinery for the entire day. Intranasal is much more practical. We do a few supervised administrations. The administration is very operator dependent to teach the technique, to observe, to find the dose. And after those few supervised administrations, the patient continues to administer at home.
That's great. Thank you. Greg, would you like to add a question?
Steve, that was really a terrific presentation. Thank you very much. On Tuesday, like 48 hours ago, the Transform 2 trial was finally published in the American Journal of Psychiatry online. I'd been looking for it. I couldn't find it, but just coincidentally, on Tuesday it was published. So I had a chance to really look at the published data, and it's really worth doing that. First of all, the MADRS score goes from 0 to 60. Higher score meaning more depression. And the difference between the two randomized groups in Transform 2, esketamine versus traditional antidepressant, was 4 points on a 60-point scale, which they do claim meets a minimal clinically important difference. And Steve, you referred to that as 1.5 to 2 points on a 60-point scale. And I really have to say that I would question that. I tried to confirm that going to the references cited. They're very old references, and they involve different drugs. So I really wonder about that. The other interesting point from Transform 2 is the time course of the improvement. All the improvement with esketamine occurred within the first 48 hours of dosing. And this is only a 28-day study, but for the remainder of the 26 days, the two curves were exactly parallel. So it's kind of an odd-looking curve. Finally, I would make the point that the article was accompanied by an editorial by Ellen Schatzberg at Stanford. And that editorial really raised some questions, concerns about how efficacious this therapy is, would there be a sustained effect with long-term treatment? And then it also raised concern about the suicides that were observed in Transform 2, but only in the esketamine group. So I'll stop there, but it was quite interesting to go through the Transform 2 article.
Just to briefly comment, I have had a chance to read it in the last 24 hours. Thank you very much. There isn't much different. There are some differences that we could talk about later between what's been published in abstract form and what's available there. There appears to be short-term benefit. As mentioned, there's concerns about sort of the magnitude of the benefit, but more importantly, the long-term safety. This was a 28-day trial.
Jill, would you like to close this out with one last question, then we'll move on to the economic modeling?
Thank you. I wondered if you could comment on Transform 1 about the lack of statistical significance and possibly clinical significance for the 84 milligram dose versus the 56.
Well, yes. So basically the methodology was that because there was no difference in the 84 versus the placebo, their stopping rules didn't allow them to report that the difference between the 56 and the and the placebo, which if you did would have been statistically significant. But they argue, and it's unclear, is that they ramped up the dose too quickly, and there were more side effects with that. Though it's not really clear why that group did not do as well as the 56 milligram. But as mentioned, those were fixed dose as opposed to a flexible dosing. So the manufacturer wishes us to avoid that population, though we included that in our meta-analysis. But I think just from a time perspective, I'm going to turn this over to Dan Touchette, who will present the results of our cost-effectiveness modeling. Dan.
Don and Ryan, I'll make sure that we get back to you on around the voting questions.
Right. Thank you. I'm Dan Touchette from the University of Illinois at Chicago, and these were the key team members who assisted with the development of our pharmacoeconomic model. We have Nikki Boye from University of Chicago. So, Steve, you were right. There is someone from University of Chicago as well. And then we have Brian Talon and Bob Schultz, who are graduate students in our program, and Varun Kumar, who is from the Institute for Clinical and Economic Review. Here are the disclosures. Brian Talon and Bob Schultz are also, aside from being PhD students, are also fellows. Their fellowship is funded through a grant from Pharma to University of Illinois at Chicago, from Takeda Pharmaceuticals to University of Illinois at Chicago. Other than this, there are no other conflicts of interest to disclose. So for our analysis, we actually have two objectives that I will be presenting today. The first was to evaluate the lifetime cost effectiveness of the addition of esketamine nasal spray plus background antidepressant compared to background antidepressant alone for the treatment of treatment-resistant major depressive disorder. That is the pharmacoeconomic model. And then we also did a cost analysis, which I will be referring to towards the end of the presentation. The objective of that one was to evaluate the one-year cost of therapy for the addition of esketamine nasal spray compared to intravenous ketamine for the treatment of treatment-resistant major depressive disorder. An important point to this is, as Steve has already presented, there are no good trials comparing ketamine to esketamine. We don't know the relative difference in clinical effectiveness of these two therapies. So as you interpret the results of the cost analysis, keep in mind that it is just a cost analysis. We're only looking at the costs. We are not looking at the effectiveness. All right, so I'm going to present the cost effectiveness model now. Here is our base case population. This was the population that was enrolled in the Transform 1 and Transform 2 trials, the average, weighted average of both of these. So we have patients who are approximately 46 years of age, 2/3 were female, about 2/3 had received, a little under 2/3 had received 1 or 2 prior antidepressants in the current course of treatment. Those who had received one therapy were actually received a second therapy before being enrolled to esketamine or placebo. So they did have 2 courses of antidepressants. And the mean MADRS score is shown there, about 37. The intervention comparator are shown here. What we're modeling is actually the FDA-approved titration of esketamine, which is for weeks 1 to 4, twice weekly at either 56 or 84 milligrams. Weeks 5 to 8 is once weekly, and then after weeks 8, those same doses can be administered either once weekly or every other week. We modeled information from the Transform 2 trial for this, which patients settled on either 56 or 84 milligrams. I'll show you what proportion of patients settled on those doses in just a few slides. And the background antidepressant varies by patient, as Steve presented. The model is a semi-Markov model with time-varying mortality. The settings, the United States. The perspective is the healthcare sector. Time horizon is lifetime. We used a discount rate of 3% per year. Importantly, we modeled 3-month cycles because we felt that was most appropriate for antidepressants and switching antidepressants. Primary outcome was cost per quality adjusted life year gain, but we did also consider cost per life year gained and cost per depression day avoided. The key model inputs for our model were taken primarily from the esketamine phase 3 studies that Steve mentioned. So those were the main inputs to our model, looking at the effectiveness of esketamine or no additional therapy. Again, both of these groups were on background antidepressant. And then other model inputs were obtained from the STAR-D trial, which was a pragmatic study evaluating numerous depression treatments. And it's really the best available study looking at longer-term outcomes in these patients. Quality gains utility was assigned to model states according to the degree of depression experienced by patients. And I'll show you a little bit of how that worked. And then the health sector costs, we included the manufacturer submitted net price and then the cost of care as determined by the number of failed prior treatments. We actually had to, after doing an extensive review on the cost of treatment-resistant depression, we had to develop our model around the data that was available. And I'll show you what the model looks like next. Here we have the model. It starts on the left, where we have the blue box is patients who are on initial treatment. So this was the randomized treatment, but now in a real-world setting, they're either getting esketamine or plus background antidepressant or just a background antidepressant. All the green boxes on this are where a therapy is effective. At the very top, we have where the initial treatment is effective. The orange box is where the initial treatment is partially effective, meaning that patients had a response but not remission. And then the green boxes below are alternative treatments, and with them being effective, and I'll walk through a single patient after this so you can see sort of how the model flows. And then the bottom boxes, the ones in red, are where none of the treatments are effective, and they move from treatment to treatment. So the model is pretty flexible in that we did consider up to 3 alternative therapies after failure of the first therapy, and then patients just remained in that third treatment at the end. Also at any point in time, patients could die of any cause in the model. So here's a patient who has initial effective treatment, and they're going along with esketamine for maybe several cycles of the model, and then they lose effectiveness and get tried on an alternative treatment. And that alternative treatment is effective. They may go through the model for several cycles and lose effectiveness of that alternative treatment and end up without any additional therapies that work in the future, or any possible combinations of those types of things. That's how the model works. And again, just pointing out that this orange box was patients who partly responded in subsequent cycles, and based on evidence from the longer-term open-label trials, some of those patients could either lose effect or gain full effect in the model. And then we also had these states that are far out to the right, and anything in this column are the same. These are states where patients could continue to have effective treatment and have their therapy discontinued because it's effective. So the long-term effect, they come off of the medication and continue to experience benefit, or not benefit of the drug, but their depression has resolved for some period of time. And then they could also move back to treatment when needed. There were some key assumptions that were needed for this model to work. The first thing is that some patients with effective treatment long-term had their treatments discontinued. So that was the example that I just gave at the end. And those whose treatments were discontinued for effect, when they did have a relapse, they would restart on the last effective therapy. That was an assumption that we made. So if they were on alternative treatment 2, they would go back to alternative treatment 2 if they had a relapse while off of that therapy. And I think that that's fairly consistent with clinical practice. The model only tracked up to 3 additional alternative therapies. Doing more would have overly complicated the model, and we didn't have data on what happens after 7 different antidepressants have been tried. So we sort of capped it at 3. Patients with effective depression treatment had medical costs equivalent to those with 3 prior treatment failures. That was the lowest cost that we had available from our source publication, which costed out therapy by number of failed treatments patients had. There's limited cost data in patients with treatment-resistant depression. So we built our model around this particular information because it was the most comprehensive that we had that distinguishes between patients who have failed multiple treatments and costs associated with those. And then treatments did not directly affect mortality, but the level of depression did. So in our model, those patients who were well treated had a lower risk of mortality than those patients who were poorly treated. So there were some indirect benefits of the therapy, but not direct benefits.
How did you account for suicide rates?
It's all part of the all-cause mortality. We had a study that looked at all-cause mortality in patients that included suicide. And so we used those risk ratios. The particular study that we used had information that was stratified by age as well, because the risk of mortality, the risk ratio itself will change as patients age because other causes of mortality increase over time. So it was, again, the best source that we could identify for that. But it was wrapped in with all-cause mortality. We did not explicitly include something for suicide. All right. Here are the key treatment model inputs. The 2 columns that we have here are esketamine plus antidepressant and antidepressant alone. You can see the proportion. The proportion of patients who had effective treatment was about 40% with esketamine, 28.8% without. Partly effective treatment was similar between the 2 groups, but a little bit better with esketamine. And then some of these others, partly effective to effective treatment, this was for those who had some partial response. Each 3-month period, some of those would continue to respond better, eventually respond better to therapy, and some would lose response. And so that was 13% in both groups that lost response if they had initial partial response. That one is for patients who had effective treatment and eventually lost response was 13%. Partly effective loss of response was 21% versus almost 50% for the antidepressant alone. And then effective initial treatment to discontinue with effect. This we could not find anywhere in the literature. There's no data on this. So we relied on expert opinion to come up with an estimate, and we used very wide parameters in our sensitivity analysis for testing this assumption. But we felt it was important to build this into the model because we wanted to see exactly how this might impact the model. Yes?
Given that there were so many concerns about harms and in addition to benefits in the prior discussion, did you model any of the harms?
We did not model the harms with these therapies.
So it just can only provide benefits?
Right.
Okay.
Right. As far as harms, the side effects of the therapies of esketamine was not much different from placebo. But the harms that were brought up about suicidal ideation is not explicitly modeled in the model. So, yeah. All right. Patient utilities are shown here. For no depression, we used population values for age-adjusted population values. Mild to moderate, we used a value of 0.68. And for severe, 0.5. Wanted to give you a little bit of an indication of what a utility of 0.5 is. And in the table that we had, there were no other utilities of 0.5 for population solicited estimates. The closest things we had were heart failure at 0.64, senility without psychosis of 0.55, which was the closest that we could find, and renal failure with 0.65. So this was much more serious than many of the chronic conditions that you'd see in large population solicited utility tables.
Is no depression 0.86?
That's the population norm for patients who are 46 years of age. So,
really?
Yeah.
Life sucks, then you die.
Have you seen your primary? That just doesn't seem.
Well, are you thinking it should be higher or lower?
Health is usually 1. I mean, unless you have something wrong with you, health is 1. I mean, either on the
but these are population norms.
Will people give up their life for what? I mean, it's just I can't figure out where the 14% is going.
Well, you have other chronic conditions, and I mean, this is a population norm. So we're not modeling someone who's in perfect health. We're modeling the population as it is at 46 years of age.
That's standard? Is that?
Yes.
Okay.
All right. Here is esketamine pricing and the annual cost. For the first year, it's a little bit more expensive than for the second year, and the first 2 rows are looking at excluding observation and monitoring costs required for the REMS piece of it. So $28,500, $27,000 in the second year and thereafter. When we do include observation and monitoring costs, it jumps to $32,000, a little over $32,000, and $30,800. The direct medical and pharmaceutical costs, these are the costs of caring for patients with depression, and this was taken from that economic paper that I described that broke things out according to the number of treatments patients had previously failed. And in the model, the initial treatment, which means that they were at least they're on an average of their 3rd antidepressant. The medical costs were a little over $10,000. The total cost was about $15,000. Again, the bars are broken out. Medical costs are the dark blue, and pharmaceutical costs are the light blue. And you can see the costs increase with every failed treatment, up to about $20,000 a year with the 3rd failed treatment in our model, which would represent the 7th failed treatment overall. And here are our results. For the base case, what we have is esketamine plus background antidepressant lifetime would cost about $448,000, almost $450,000. This is all of the costs that we included in the model. This is not just drug costs, just so it's clear. Whereas background antidepressant would be $410,000 for a difference of $38,400. The QALYs are shown in the next column. So 12.66 for esketamine lifetime QALYs and 12.47 for background antidepressant with a difference of about 0.19. Life years gained are shown there. The difference is very small, is 0.01 life years gained, and depression-free days was 250 days lifetime. There was an important, well, I'll get to it in a second, I guess. So, oh, yeah, I remember what it was. The important thing that I wanted to mention that's not shown in these results, the vast majority of the benefits with esketamine were in the first 5 years of therapy with esketamine. In the longer-term trials, there is a fairly high discontinuation rate, about 20% at 6 months. And by the 5 years, applying that rate as a constant, again, we have no data beyond 6 months, so we don't know if that discontinuation rate continues or if it, if it plateaus or what happens. But we applied that rate for the entire period of the study, and patients had pretty much discontinued esketamine by about 5 years. So there were a very small number of patients continuing to take it. Here are the base case incremental cost effectiveness ratios. So esketamine was $198,000 per QALY gained, and about $150 per depression-free day. again, because there was very minimal impact on life years gained, that ratio is not very helpful. Yes.
Discontinuation.
You want to press your mic, please?
Just on that last slide, when you talked about the discontinuation, it did seem to me with a therapy like this, it might be intuitive to think that there's heterogeneous responses to that and that a bunch of people don't like it and quit. And it seems like it seems like a fairly strong assumption that it would continue, that you would have sort of a constant hazard rate that continued in that way. Have you sort of looked at other ways to model that, just to sort of sensitivity analysis type stuff?
Yes, we did include that in our sensitivity analysis. I mean, there's a number of different ways to look at it. What we did not do is apply a table, which would allow for varying discontinuation rates over time, because that would have been a relatively complicated analysis, and we have no data to know what to put in the table is probably the bigger reason for not doing that. It looked like the discontinuation was a fairly constant rate. We did compare the rate over time for that 6 months, and it was a fairly constant rate over the 6 months, but we don't have data beyond 6 months, so it's hard to extrapolate, or to predict what might happen beyond 6 months. Yeah. And here are the one-way sensitivity analyses that we, only some of the ones we ran. The full set are in the report. These are the ones that had the biggest impact. And so severe depression, the utility of severe depression had the largest impact, and that's because for the alternative treatments, or actually for anyone beyond 5 years, eventually people ended up back in a state where they were not receiving benefit from any of the available therapies. And so because they remain in severe depression for a long time in the model, that one is a very important part of the model. And then the probability of continued effect, as I mentioned before, where we had, this was varied between 0 and 50%, not knowing what the likelihood would be of patients discontinuing therapy for continued effect. And it does have, when varied up to 50%, it does have a fairly large impact on the model. In our probabilistic sensitivity analysis, we see that for 50,000 and 100,000 per quality gained thresholds, we saw none of the iterations achieved that level of cost effectiveness. At 150,000 per quality gained, we did see a 15% of our trials in the PSA reached that level of threshold. And then we did a scenario analysis that included labor benefits for the proportion of patients who worked, and assuming that they would be able to work again once their depression resolved. And that improved the cost per quality value to 188,000. So it had some impact, but a very small impact overall.
Hey, Dan, I think Jill has a question.
Sorry. Yes. Oh, sorry.
So I'm noticing from your first, second, and third alternatives that you priced those antidepressants at a list price from 2000 inflated to the year 2018.
Yes.
Over the last 18 years, though, many, if not all of those drugs have gone generic and probably have been assigned a maximum allowable cost, which makes them pennies. So a year of treatment might cost hundreds rather than the thousands, which would actually worsen the cost effectiveness of esketamine. But I just wanted to make that point that it's not that expensive to use the drugs that are available to us now orally. So those thousands are kind of eye-popping when they're probably not really that expensive.
Sure. Yeah, absolutely. And again, we're using the data that was available. That cost analysis that we used does not do a good job of describing what those pharmaceutical costs were. They were just out there for us to use. So we use sort of standard processes, but that's an important observation, yes. All right, the limitations, and this gets at what we've been discussing. There's a lack of comparative effectiveness data of esketamine to other commonly used TRD treatments. The number of lifetime treatment failures, severity of depression, and patient course of TRD are likely important factors that are not well captured in the evidence base. And caregiver burden, underemployment, and reemployment are important societal costs that are not captured in the evidence base. So it was difficult to incorporate any of these. Anything we did would have been just hypothesizing what these were. We need a lot more research in this area to better understand what some of these costs are. In the public comment summary, they pretty much followed those same comments. There were a number of alternative inputs that were suggested. We did, as a transparency project, we did share our model with the manufacturer. So many of the comments were from the manufacturer saying, well, if you change this input, and this input to these values, it would, the product would look better overall. And here's some of the ones that they commented on. The Transform 2 data should not be used alone, as you heard. So we used the meta-analysis. They wanted the Transform 2 data alone. Discontinuation for long-term effectiveness. Again, we used expert opinion. There is no other data out there on that. Mortality risk, they believe, was underestimated, especially suicide risk, which might get to your question as well. And then the cost inputs. There were alternative suggestions for cost inputs, but we did a thorough systematic review of the literature, and we felt that this particular paper was the best one that was available. The other cost inputs were also from a similar era. They're from the early to mid-2000s and didn't break costs out in a way that we could use in the model. So it was difficult to work with those inputs. And then health-related quality of life and utilities do not fully capture the patient experience. All right, now I'm going to present on the cost analysis very quickly. And so for this, we use the same dosing schedule for esketamine, and for ketamine, we used a dosing schedule of twice weekly for 2 weeks, reduced to every other week or once monthly thereafter at a weight-based dosing. We used a deterministic model, settings United States, healthcare sector, time horizon of 2 years total, but we looked at annual costs of care. We did 2 years because the first year is more expensive than the second year, so we wanted to give some idea of what ongoing costs would be for year 2 and beyond. And then primary outcome was cost of care only. Sorry. And then so we compared esketamine administered in the physician's office to ketamine administered in a ketamine clinic, which are the sort of the expected ways that these drugs will be administered. The costs we included were drug acquisition costs and physician office visits, including administration and observation costs. And then we conducted a scenario analysis from a modified societal perspective that included employment-related costs as missed days of work. And here are our results. You can see there's a large difference of about 30,000 between the two. Again, one of the key points that I want to make with this slide, again, this is a cost analysis only. We are not looking at the relative effectiveness of these two therapies. We're not implying that they are the same. This was intended solely as a cost analysis. And so our conclusions are that long-term cost effectiveness of esketamine plus antidepressant compared with an antidepressant alone. Esketamine provides gains in quality-adjusted survival, but primarily in the first 5 years of treatment. Again, that might be different depending on how long patients are able to remain on esketamine. Esketamine appears to be priced higher than the modeled benefits would support, and many patients were discontinued treatment with esketamine in longer-term studies, but we don't have information on the long-term effectiveness of esketamine. The short-term cost of esketamine compared with ketamine, there's very little evidence or no evidence directly comparing esketamine to ketamine. There's limited evidence for the effectiveness of ketamine for treating patients with TRD, and the annual costs for ketamine appear to be substantially lower than for esketamine. And with that, I'll take any other questions you might have.
We have just a couple minutes for questions. Anybody else? Reem, please.
So thanks for the presentation. I just want to follow up on my previous question and the point Jill mentioned, to me, when I'm thinking about the limitations of this cost effectiveness, cost analysis, is I think of every one of these limitations, the way it will change the effect is actually that it's worse. So if we actually consider mortality as higher, that will look worse. If we take the prices of the other medications lower, that will look worse. Is there any scenario that you considered or any of the limitations of what you've done that will actually show that the actual costs are better?
Yes. And that would be the probability of continued effect if the drug is discontinued. And I think that depends on your starting population. If you're starting with a population who have failed 2 treatments and the drug appears to be effective for 6 months, a year, 2 years, at some point you may choose to discontinue the drug and you may still obtain effect, or well, not effect from the drug, but no depression for some amount of time. But we won't know this information for years. But that's the only scenario where we saw some potential sort of benefit of changing that parameter, benefit for esketamine.
Don, do you have a question that you'd like to add?
Well, it's really sort of related to this, but it's a large-scale question around the populations that were in these trials. Because what I'm struggling with is, first of all, I appreciate Dr. Kerfman's points that he made, and I share his concern relative to the clinical issues. But my question relates to understanding what other comorbidities are in these populations. Because if I look, especially at Transform 3, the likelihood of more people with chronic illness, the middle-aged groups with situational situations, substance abuse, the young population with the presence of type 1 diabetes or, eating disorders, things like that. It just seems so heterogeneous. And so what I'm concerned about is when we start talking about the probability of effect and effective treatment, I get lost immediately in terms of the vast heterogeneity that I would expect in all these different subpopulations. So relative to your analysis, economically, I don't think it changes anything dramatically, but it does worry me. And it gets back to Tim's, question about what is the effect and how do these other factors, which I personally know have a vast impact on the treatment effects, how does that get factored in here?
It gets factored in at the population level. So a lot of the data that we've used incorporates that heterogeneous group. I mean, they're large claims database analyses typically that we've used for our economic inputs as an example. And so they're capturing comorbidities, they're capturing other things. When it comes to mortality, we may have a limitation there because, the study may have been done at a time when there was maybe less substance abuse issues. So we might be missing some of the effects.
From a clinical, Don, that's a great question. Number one is, on the psychiatric side, all of those patients were excluded in the trials. So they're just out. So we have no idea. And then on the comorbidity side, there's no data. And it's most relevant, you're absolutely right, for the greater than 65. That's not been published, but there's no data in any of the trials about non-psychiatric comorbid conditions. So there's no published data to say whether these patients may be, the cream of the crop, both in terms of just depression and not having anything else. And then particularly for older individuals, the issues around, these are pretty significant increases in short-term blood pressure. I would not be wanting to put someone who has bad heart disease, bad vascular disease, bad blood pressure control on one of these meds, particularly if they're older.
Albert, can you be our last question for this part of the session?
Sure. I have a fairly broad question for both Steve and Dan. I'm trying to understand the the conclusions from the original review of the trials and how they fit into the randomized controlled trial. The problem I'm having is I don't understand the outcomes very well. So I understand that we have continuous measures like the MADRS score, and then we have categorical outcomes like remission or not remission. And I'm assuming, Dan, that in your model you do not deal with that you're just dealing with the outcomes in one form, probably categorical, not. Correct. And how do the continuous outcomes versus the categorical outcomes? What do they tell the same story about the drug, esketamine or ketamine?
So yeah, I'll let you comment on the clinical part, and then I'll comment on the.
So in the clinical, in short term, the drugs appear across multiple measures to have some measurable benefit. From what experts and patients tell us, remission is the outcome of choice, and that's what we focused in terms of the model on.
Yeah. And as far as the MADRS being continuous, it's not really, it's still a categorical scale. It has 60 categories. What we did was we broke it up into 3 broad groups that are full response, partial response, and insufficient response. And in those situations where they were insufficient, they would switch therapies. If they had partial response, the assumption in the model was that they would have some type of augmentation. Move at some point in time, move in either direction to full response or not. So we made it more categorical even. Yeah.
Thank you. Thank you, Dan. Great presentation and excellent discussion.